Here we present a case of the peroneal tendoscopic debridement and endoscopic group deepening in the prone position. The indications are the peroneal tenosynovitis, not relieved by conservative measures, a low-lying muscle belly of peroneus brevis, and flat, shallow or convex surface of the retromalleolar groove. Contraindications are the acute and recent onset of peroneal tenosynovitis with extensive peroneal tendon tears, extensive scarring, and patients with cardiopulmonary disease. This is the sagittal plane MRI T2 weighted image showing eye signal intensity indicating peroneal tenosynovitis. This is the sagittal plane MRI showing low-lying peroneus brevis muscle over the retromalleolar area. Axial image showing shallow retromalleolar groove and low-lying peroneus brevis. For spinal anesthesia, the patient was placed in the prone position. The prone position was used because it provided better access for making the portals and better convenience during movement of the arthroscope with greater ergonomics. Pneumatic tourniquet was applied in the proximal thigh. Proximal incision was given 6 cm proximal and 1 cm posterior to the posteriormost aspect of the fibula. On the basis of the proximal portal tendoscopic visualization, distal portal was made 5 to 10 mm distal and 3 to 5 mm posterior to the tip of the fibula. The proximal viewing portal and the distal working portal may be changed according to the location of the pathology. This is the tendoscopic visualization from the proximal portal. The viewing portal is the proximal portal of the left ankle in the prone position. The working portal is the distal portal. The arthroscopic video system is at the head side of the patient. The arrow showing the right is the medial side of the ankle, the left is the lateral side of the ankle, upper is the anterior part of the ankle, and the lower is the posterior part of the ankle. The peroneus brevis tendon was identified by the presence of muscle belly and the space inside the peroneal sheath was identified. There was a shallow and flat surface of the retromalleolar groove. Thus, endoscopic groove deepening and smoothening prevents subluxation and irritation of the tendons. The superficial tissue of the groove was removed, about 6 to 7 mm in width, 2 to 2.5 mm in depth, and a length of 10 mm proximal to the tip of the fibula was made, which was judged by the diameter of the saber, which was 4.2 mm. Tenosynovectomy was done with the resection of hypertrophic synovium and release of adhesion with arthroscopic saber. Here the low-lying peroneus brevis muscle is being resected. The low-lying peroneus brevis muscle is an anomalous extension into and distal to the retromalleolar groove, which causes crowding of the groove and is a precursor of tendon irritation, tenosynovitis, tendon instability including subluxation and dislocation. Some surgeons recommend elective resection of a low-lying peroneus brevis muscle in the groove, which will allow a better gliding ability of the tendons and as they course around the ankle. After the completion of the procedure, the movement of the peroneus longus was assessed by the plantar flexion of the first ray. Movement of both the tendons was assessed by the eversion movement of the foot. The gliding movement of the tendons was assessed by circumduction of the foot and ankle. During the circumduction movement, there was no subluxation or dislocation of the tendons. After the completion of the procedure, a non-absorbable horizontal mattress suture was applied, the posterior splint was applied, and the patient in this video had quick recovery in terms of pain and swelling during the second week follow-up.